It's board season, and today we're going to be doing the GI or abdominal review. Let's begin with a discussion of the abdominal wall. There's really only one bit of pathology we need to know for the abdominal wall, and that is hernias. Hernias are a protrusion of any viscus from their proper cavity. There are really only two kinds of hernias we need to be aware of: incarcerated hernias and strangulated hernias. As you might suspect, incarcerated is not as bad as strangulated. It's stuck and irreducible. A strangulated hernia, on the other hand, is one in which the vascular supply is compromised, which can produce ischemia or infarction in the involved viscus. Clinical signs include nausea, vomiting, pain out of proportion, which is consistent with ischemic type pain, and eventually there are peritoneal signs with infarction. There are 5 types of hernias we need to be familiar with: inguinal, femoral, obturator, ventral, and umbilical, although it's likely only inguinal will be asked about. The reason is there are direct and indirect inguinal hernias. Direct hernias protrude through Hesselbach's triangle, and they rarely incarcerate. Indirects project through the internal inguinal ring lateral to the inferior epigastric vessels and are more likely to incarcerate. This is the most common type of hernia in males and females. Now we're going to move down the GI tract into the esophagus, beginning with infectious disorders of the esophagus, and there's really only one of these we really need to know about, and that's Candida esophagitis. This is most common in immunocompromised patients. It happens to be an AIDS-defining lesion. Patients typically present with odynophagia. They may also be dehydrated. It's treated with a 10-day course of fluconazole, and follow-up needs to be for endoscopy to rule out herpes and CMV. Moving on to esophagitis and GERD. These present with a retrosternal burning. It radiates from the epigastric area to the throat and is worse when recumbent. It can be associated with dyspepsia. Reflux can also cause extraesophageal manifestations like cough, hoarseness, and wheezing, and these can present without the classic esophageal-related symptoms. Symptoms typically resolve with antacids. This is treated with H2 blockers or PPIs and referral to a gastroenterologist. Complications include Barrett's esophagus, which is a premalignant condition, strictures, bleeding, and esophageal perforation. Inflammatory problems can also be caused by caustic ingestions. This can be acids, which produces coagulation necrosis, or alkali, which produce liquefaction necrosis and has a worse prognosis than acids. Particularly with alkali ingestions, these can produce airway compromise from edema, esophageal perforation, stricture, scarring, and ultimately carcinoma, although this is long-term. Ultimately, treatment from the emergency perspective is to get an emergent GI consult for endoscope. Don't lavage, don't try to neutralize, don't induce emesis, and don't give charcoal. Moving on to motor abnormalities of the esophagus. The only one we need to know about is esophageal spasm, and this only because it typically mimics angina. It can improve with nitrates or calcium channel blockers, but it's usually precipitated by foods, in particular cold foods. Now moving on to structural disorders. To begin, we'll talk about esophageal diverticula. The important points are that patients present with dysphagia, aspiration, and food regurgitation, in particular undigested food. Next up is foreign body impaction. The most common levels of obstruction are the level of the cricopharyngeal muscle, more common in children, the aortic arch, and the gastroesophageal junction, most common in adults. It's worth noting that 80 to 90% of foreign bodies will pass once they reach the stomach. Meat impactions are one of the more common ingested impactions. This happens more common in the elderly because of underlying anatomic abnormalities, again, particularly at the GE junction, and these usually pass spontaneously. Treatment can include glucagon, which relaxes the lower esophageal sphincter, though this can result in nausea and vomiting. Nifedipine, which reduces esophageal tone, although this can result in hypotension. And ultimate treatment is endoscopy. Swallowed coins in the esophagus will present in face, with the flat part of the coin pointed toward the X-ray in an AP X-ray, as seen on the left. Aspirated coins, on the other hand, will present on their side as seen on the right, and this is because of the tracheal rings. Coins in the upper esophagus should be removed endoscopically because of their risk for aspiration. Coins in the lower esophagus can be allowed to pass over 12 to 24 hours and removed endoscopically if they fail to pass. Sharp objects should be removed even if they reach the stomach, as up to a third of them can cause perforation. Large objects, namely objects larger than 2 by 5 centimeters, will also need to be removed as they are unlikely to pass beyond the stomach. Ingested button batteries are a true emergency in children, as they can cause significant burns within 4 hours and perforation within 6. These must be removed endoscopically as soon as possible. If the button battery has reached the stomach, the patient can be observed for 48 hours to see if the battery will pass. If it fails to pass, or if the patient develops any symptoms, it must be removed endoscopically. Some people intentionally ingest foreign bodies, such as drugs. There are 2 types of this: body packers, who are drug smugglers who ingest large amounts of carefully wrapped drugs, effectively packing themselves, and body stuffers, who ingest small amounts of poorly wrapped drugs, usually to avoid getting caught. Generally speaking, body packers should be admitted with consideration for whole bowel irrigation, as rupture of these packets can ultimately cause death, depending on the drug ingested. Moving on to hematemesis. Hematemesis can be caused by ingestion of sharp objects, alkali substances, but more commonly, we encounter Mallory-Weiss tears or esophageal varices, and at the extreme, Boerhaave syndrome or esophageal rupture. Mallory-Weiss tears are partial thickness tears, usually caused by intense vomiting, and these typically heal spontaneously. Boerhaave syndrome, on the other hand, is a full thickness tear. It usually happens in the left mid-thoracic region of the esophagus. This is most commonly caused iatrogenically, usually during endoscopy, but classically presented as a result of intense vomiting or retching, hence Boerhaave syndrome. The classic triad is intense vomiting, chest pain, and subcutaneous emphysema. Esophageal rupture causes the esophageal and gastric contents to spill in the mediastinum, causing mediastinitis. Diagnosis is clinical, but can be supported by chest X-ray, which typically demonstrates either pneumothorax or pneumomediastinum, left pleural effusion, and subcutaneous emphysema, as shown here. Treatment is broad-spectrum antibiotics and emergency surgery. Esophageal varices account for about 6% of all upper GI bleeds, but have a high recurrence rate and an incredibly high mortality. The most common cause in the United States is alcoholic liver disease causing portal hypertension. Treatment is IV fluids, blood transfusion, potentially a Blakemore or Minnesota tube in extremis, and you can consider octreotide and vasopressin if necessary. Endoscopy is reported to be highly successful at controlling hemorrhage, and if this fails, a transjugular intrahepatic portosystemic shunt or TIPS should be considered. Also, remember to give antibiotics, in particular ceftriaxone or fluoroquinolone, as this reduces mortality, infectious complications, and rebleeding rates. Tracheoesophageal fistulas are typically diagnosed in the neonate, secondary to coughing, choking, and cyanosis during feeding. These can be associated with esophageal atresia and require surgery for correction. Esophageal strictures and stenosis is usually caused by severe GERD. This usually presents as dysphagia with solids, progressing to dysphagia with liquids. It can be diagnosed with a barium swallow study and ultimately requires esophageal dilation. Moving down the esophagus into the stomach, let's consider some of the pathology that we may see. There are really only 2 primary infectious and inflammatory disorders of the stomach that we should be aware of, and that is gastritis and peptic ulcer disease. Gastritis refers to diffuse mucosal involvement of the stomach, while peptic ulcer disease refers to the presence of ulcers. Both of these are most commonly caused by the bacteria Helicobacter pylori or NSAIDs. Alternative etiologies can include potassium or iron or alcohol. Patients tend to present with epigastric pain, nausea, vomiting. They may have burning or hunger-like pain several hours after meals, and it classically awakens patients from sleep at about 3 a.m. It is worth noting that duodenal ulcers are the most common cause of upper GI bleeding. Treatment includes antacids, H2 blockers, PPIs, mucosal surface protectants, and then treatment at the underlying cause. There is really only one structural disorder of the stomach we need to be aware of, and that is congenital hypertrophic pyloric stenosis. And this is the most common cause of infantile obstruction after the first month of life. This classically presents between 2 and 6 weeks of life with projectile, non-bilious vomiting. Labs demonstrate a hypochloremic, hypokalemic, metabolic alkalosis, a palpable pylorus or olive on exam, and this requires surgical consultation. Moving on to the liver, gallbladder, and pancreas. We begin with the discussion of cirrhosis, or irreversible scarring of the liver. The most common causes include alcoholic cirrhosis and chronic hepatitis C. Patients present with peripheral edema, ascites, jaundice. Remember to look for sublingual jaundice and sclerolicterus, and at an extreme, hepatic encephalopathy. Hepatic encephalopathy is altered mental status caused by an accumulation of toxins in the blood. It can be precipitated by infection, certain medications, anything increasing the nitrogen load to the liver, which can be dietary or GI bleeding, diuresis, hypoxia, and hypoglycemia. Patients present with an altered mental status, asterixis, which is a kind of flapping of the extremities, and an elevated ammonia level. Treatment includes supportive care, addressing the underlying cause, and administration of lactulose and neomycin. Ascites is accumulation of fluid in the abdomen, which in itself is uncomfortable but not typically life-threatening. However, it does predispose these patients to spontaneous bacterial peritonitis, which is concerning. Spontaneous bacterial peritonitis includes fever, ascites, abdominal pain, increased liver function tests, although 30% are asymptomatic. It's diagnosed with paracentesis cell count and culture. The most common organisms are E. coli and Streptococcus species. Treatment is with broad-spectrum antibiotics, such as piperacillin, tazobactam, and imipenem. Moving on to liver abscess, 40 to 50 million people worldwide are infected with Entamoeba histolytica. Patients tend to present with fever and right upper quadrant pain in the setting of a correct epidemiology, which has traveled to an endemic area. There is a cystic cavity on liver imaging, usually solitary, and treatment includes a tissue agent like metronidazole, followed by a luminal agent like paromomycin. Pyogenic abscesses usually result after peritonitis or direct spread from biliary infection. They present with fever and right upper quadrant pain, and treatment involves drainage, whether needle aspiration, percutaneous catheter drainage, or surgical, and antibiotics. Moving on to hepatitis. This is, of course, inflammation of the liver. It can be caused by the hepatitis virus, CMV, and chemical and other hepatotoxins such as acetaminophen, alcohol, halothane, and isoniazid. Beginning with hepatitis A, this is an RNA virus that spread from the fecal to oral route, person to person, or through the ingestion of contaminated water or food. There's an incubation period of about a month and usually has a mild course that resolves on its own. Hepatitis B is a DNA virus. It's spread typically by injection drug use or sexual contact. 5 to 10% of infected people will develop a chronic carrier state, and this predisposes them to hepatocellular cancer. It's most worth remembering that the surface and envelope antigens represent active infection. Hepatitis C is an RNA virus. It's the most common cause of viral hepatitis in the United States, and it's most often acquired through IV drug use, though it can be transmitted sexually. Acute illness tends to be milder with hepatitis C than in hepatitis B, but anywhere between 50 and 85% of people infected develop a chronic carrier state. Hepatitis D is a defective RNA virus. It requires hepatitis B for co-infection, but it does increase the mortality of hepatitis B, as well as the transition to cirrhosis and the chronic carrier state. Hepatitis E, like hepatitis A, is an RNA virus spread by the fecal-oral route. It does, however, have a higher rate of fulminant hepatic failure, particularly in pregnant women. Lastly, cytomegalovirus is a latent liver infection. It tends to reactivate with immunosuppression. It is the most common viral opportunistic infection in liver transplant and is treated with ganciclovir. Moving on to chemical and toxin-mediated hepatitis. Alcohol is the most common form of chemically induced hepatitis. Patients with alcoholic hepatitis can present with acute hepatic failure or cirrhosis, right upper quadrant pain, weakness, anorexia, nausea, jaundice, and dark urine. Lab results can include pancytopenia, increased transaminases, usually 2 to 10 times normal or more, usually with a 2-to-1 ratio of AST to ALT, an elevated INR, and hypoglycemia. Treatment is supportive with the goal of managing GI bleeds, hypotension, and coagulopathy, ultimately treating alcohol withdrawal and provide glucose as needed. While there are many other hepatotoxins, including halothane, methyl-dopa, isoniazid, and phenytoin, the real two worth knowing are acetaminophen and mushrooms. The primary reason for this is that these can cause massive hepatic necrosis, and these patients are often asymptomatic until it's too late. If there is concern for a significant Tylenol overdose or mushroom ingestion, N-acetylcysteine should be given, preferably within 8 hours. Moving on to disorders of the biliary tree. Cholelithiasis is stones in the gallbladder, and choledocholithiasis are stones in the common bile duct. Patients classically present with right upper quadrant pain radiating to the right scapula 30 to 45 minutes after eating fatty meals. When there are no other symptoms, this is a self-limited process called biliary colic. When the cystic or common bile duct become obstructed by a stone and the gallbladder becomes inflamed, we call that cholecystitis. Although 5 to 10% of cholecystitis cases are considered acalculous. This is diagnosed with a positive sonographic Murphy's sign, 3 millimeter thickening of the gallbladder wall, the presence of pericholecystic fluid, stones or sludge in the gallbladder, and, if you can see it, a dilated common bile duct. Cholangitis is a purulent biliary tree infection. It involves Charcot's triad of fevers and chills, jaundice, and right upper quadrant pain. With the addition of altered mental status and shock, this constitutes Reynolds pentad, which carries with it a higher mortality. Treatment includes early broad-spectrum antibiotics and consultation for either ERCP or percutaneous drainage. Complications can include perforation, gangrene, and abscess formation. And treatment is IV antibiotics, IV fluids, and surgical consultation. Moving on to disorders of the pancreas. The primary disease of the pancreas in emergency medicine is acute pancreatitis. Alcohol and gallbladder disease are the top 2 most common causes of acute pancreatitis, and alcohol is the most common cause of chronic pancreatitis. This classically presents with epigastric pain radiating to the back, nausea, vomiting, and dehydration. Findings on testing can include an elevated lipase, pancreatic calcifications on abdominal X-ray, left pleural effusion or ARDS, or most reliably, pancreatic edema on CT of the abdomen. We establish a prognosis using Ranson's criteria. On admission, that's age greater than 55, glucose greater than 200, white count greater than 16, LDH greater than 350, and AST greater than 250. Treatment is supportive with IV fluids, bowel rest, analgesics, and antiemetics. The classic presentation of pancreatic tumors is painless jaundice, though they can present with epigastric pain, jaundice, weight loss, and anorexia. Look for Virchow's node in the left supraclavicular node or Sister Mary Joseph's node in the periumbilical region. These are highly lethal and often present late. And that is the conclusion of the GI Review Part 1. In GI Review Part 2, we'll review small bowel, large bowel, and the rectum.